All right, let's dive into one of the biggest paradigm shifts we've seen in modern orthopedics, how we manage midshaft clavicle fractures. What we're going to cover today is a really high-yield review, basically synthesizing all the evidence that's moved us from that old dogma of non-op care to a much more nuanced, selective surgical approach.
For more than half a century, this was just the way it was done. It was ingrained in all of our training. The classic papers by Neer and Rowe back in the 60s, they set a really powerful precedent. Clavicles just heal. The idea of a non-union was treated as something incredibly rare, almost a clinical curiosity. And that thinking really shaped the standard of care for generations.
But here's the catch, and it's a huge one. It's the foundation of this whole discussion. Those classic, influential papers, they had a critical selection bias. They systematically left out the very fractures that give us the most trouble today, the ones that are significantly displaced and shortened. If you can grasp this one limitation, you'll understand the entire shift in our thinking.
So how did this massive shift in thinking actually happen? Well, it wasn't overnight. It was a really systematic process of challenging that old consensus, one high-quality study at a time.
Let's just walk through the timeline. After the dogma was set in the 60s, things were pretty quiet. Then, fast forward to 2004, Robinson and his colleagues published a really influential study that identified clear risk factors for non-union, things like displacement and comminution. And that really set the stage for the game changer, the 2007 Canadian Orthopedic Trauma Society, or COTS, randomized trial. And later, studies like the one from Waltz in 2017 helped us fine-tune our understanding of the functional outcomes.
To even apply this new evidence, we all have to be speaking the same language. That vague term, displaced, it's just not good enough anymore for making critical clinical decisions.
This is where we need to be precise. When we talk about a displaced fracture in the modern literature, we're talking about quantifiable metrics, 100% or one full shaft width of displacement, at least 15 to 20 millimeters of shortening, or significant comminution, like a Z-type pattern or butterfly fragment. These aren't just incidental findings on an X-ray. They are proven predictors of a poor outcome if you treat them non-operatively.
Right. So now that we have a clear definition, we can really dig into the high-level evidence that directly compares surgery versus non-operative care for these specific injuries.
And here it is. This is the core finding from that landmark 2007 COTS trial. For this very specific group of patients, those with displaced midshaft fractures, the non-union rate with just a sling was a staggering 15%. Now compare that to just 2% in the group that got plate fixation. That's a 7-fold reduction in non-union. A finding that dramatic in a well-done RCT, well, that's what forces an entire specialty to change its practice.
But look, avoiding a non-union is only half the battle. The work by McKee and others really brought this to light. They showed that even fractures that do heal can leave patients with serious functional problems if they heal short and malunited. Patients were reporting things like reduced strength, fatigue, pain, and these symptoms correlated with objective findings like scapular dyskinesis and messed up mechanics. So the takeaway is crucial. Radiographic union does not automatically equal a good clinical outcome.
Now, this does add an important layer of nuance. Later RCTs, like the one from Waltz, show that while surgery leads to better functional scores early on, those differences tend to get smaller by about the 1-year mark. This doesn't mean surgery isn't beneficial, it just clarifies what the benefit is. The primary, lasting advantage is the reliable prevention of non-union and symptomatic malunion, with the bonus of a faster recovery in those early months.
Okay, so let's say you and the patient have decided to go ahead with Cercaller's fixation. What are our evidence-based options, and what are the trade-offs we need to be talking about?
Plate fixation is still the gold standard. It's what was used in almost all of those landmark trials. It gives you rigid, reliable fixation, which is absolutely key for getting patients moving early. Its biggest downside, as we all know, is symptomatic hardware. You could be looking at a second surgery for removal in up to 15% of cases. The alternative, intramedullary fixation, gives you a smaller incision and less soft tissue stripping, but it just doesn't provide the same rotational control and is generally not a great choice for comminuted fractures.
This table really frames a conversation we need to have with patients. It's a trade-off. With non-operative management, you're trading the risks of surgery for the risks of non-union and a painful malunion. With operative management, you're swapping those risks for the risks of infection, hardware irritation, and maybe another trip to the OR. And a key point here is that fixing a non-union down the road is a much bigger, more complex operation with worse outcomes than just getting it right with a primary fixation when it's indicated.
Okay, so let's pull all of this evidence together into a practical step-by-step algorithm that you can actually apply in your clinic or in the ED.
First up, the indications. The absolute ones are the no-brainers, right? Open fractures, skin tenting, any neurovascular compromise, a floating shoulder. Those have to be fixed. The real conversation is shifted to the relative indications, which are now backed by strong evidence. We're talking shortening of 20 millimeters or more, 100% displacement, comminution, and of course, crucial patient factors like a young, high-demand athlete or a laborer who needs to get back to work.
So here's how the process should look. 1. Rule out any of those absolute must-fix indications. 2. Get out your measurement tools on PACS and actually quantify the injury. Is it shortened by 2 centimeters? Is it completely off-ended? 3. Look closely at the fracture pattern. Is it a simple 2-part break, or is it a complex, comminuted pattern? And finally, step 4. This is where you sit down and have a real conversation with the patient about their job, their hobbies, their expectations, and their goals.
All right, so to wrap this all up for a board review or just a quick mental checklist. The old dogma was flawed because it was based on incomplete data. Displacement and shortening are the key variables you need to measure. High-level evidence from RCTs confirms that for these specific injuries, surgery dramatically lowers the non-union rate and helps with early function. And, maybe most importantly, the treatment plan has to be individualized through shared decision-making with your patient.
So look, we've moved from a really simple, one-size-fits-all world to a much more sophisticated, evidence-based algorithm. The era of never operate on a clavicle is definitely over, but the answer isn't to always operate either. The real question for all of us as surgeons is how do we take this wealth of data and apply it thoughtfully, one patient at a time?